Welcome to No Laughing Matter with Cuba Pete, a show that takes a critical look at the disparities between medical school education and society's growing healthcare iniquities. Join Dr. Pedro Cuba Pete Greer each episode as he interviews the experts working to transform medical education and ensuring that future doctors are trained to provide equitable and compassionate healthcare for all communities. Dr. Greer received the Presidential Medal of Freedom in 2009, honoring his dedication to providing health care to underserved populations. As Dean of Roseman University College of Medicine in Las Vegas, Dr. Greer is committed to creating a medical school of the future where students embrace the need to unite the heart and science of healthcare. And now, the host of No Laughing.
Welcome to Cuba Pete, live from Studio A in Las Vegas, Nevada. Hi, I'm Pedro Jose Greer. They call me Joe. I'm the Dean at the Roseman University College of Medicine. And Cuba Pete, No Laughing Matter, is about the intersection of society, health outcomes, and medical education. We are beginning a new medical school that we hope to open in the next couple of years down here in Las Vegas. It's at the Roseman University, and we want to do it right. We rank 38th in the world in health outcomes, but #1 in expenditures. We're not even #1 in patents anymore. That's because a lot of the companies have left Switzerland for tax reasons. But however, having said that, a country that has the most patents but the worst health outcomes of any industrialized nation is an embarrassment. And we have to produce the future workforce on how to keep people healthy. Because in healthcare, unfortunately, in medical school, we don't teach you about health. We teach you about disease, how to intervene, and keep going. I'm myself a super subspecialist. I'm an internist, gastroenterologist, liver surgeon, liver specialist, and we were with the original liver surgeons when we did the very first transplants. And looking at all that and being on a transplant team and realizing, why do I have to do this with a disease that we can prevent, hepatitis C, which was the most common cause of liver transplantation. And by the way, for quite a while, the #1 cause of death in HIV patients in the East Coast of the United States. Why do we wait until they progress to a state that we need to replace the organ as opposed to the prevention of it? And that's where we are in society right now. And we have a very special guest, a person that came to our attention actually when Dr. Cheryl Brewster invited her to come and teach yoga during the A Rose Grows in the Desert, teaching yoga to kids that have probably never heard of yoga. I've never tried it, but I've heard of it. My wife loves it. And the idea that things like yoga, which she is one of the experts in, and also of several types of yoga. You had she's like a black belt. I forgot the actual acronym that goes along with it and the numbers in yoga. But having said that, Dr. Whitney Koch Owens, and I pronounce it correctly?
Cook.
Cook. I was close. Come on. English is my second language. And this one's German. Is a licensed psychologist. She got her doctoral degree in the Illinois School of Professional Psychology in Chicago, and she did her postdocs at Valparaiso in Indiana. She arrived in Las Vegas in 2008 and has not looked back once. She has not even thought about the extreme cold that the Midwest gets and nobody knows about. She's a very accomplished professional. She served for over a decade on the executive board of the Nevada Psychological Board, and she was actually its president 10 years ago, 2013 to 14. That's very impressive. And she's currently the president of the Nevada Board of Psychological Examiners. That's why whenever one psychologist passes another, they say, "Hi, how am I?" Just kidding. And she teaches all different styles of yoga. Right now, in my opinion, sorry about that. The number one public health problem in America is mental illness. And we've seen that increasing and increasing and increasing. In 2017, an economist from Princeton, Ann Case, who does morbidity and mortality studies, her husband also at Princeton is a Nobel Prize laureate, and she wrote a paper entitled Deaths of Despair, that for the first time since 1917, when we had the other flu, and then we had World War I, mortality and morbidity in this country was going up. The interesting thing about her study was the demographics of those that were dying. They were baby boomers. They were overwhelmingly men, and they were overwhelmingly non-Hispanic white. What was the one common social determinant they had? They didn't do education beyond high school. What were they dying of? Suicide, opioid overdose, and alcoholic liver disease, all which have underlying behavioral health issues. And as a gastroenterologist, I'm going to tell you that at least 80% of my patients that would come in with GI symptomatology, it was all based on a behavioral health issue, whether it was anxiety, stress, et cetera, lifestyle. And it would manifest itself in the GI tract. And why is that? Because from the mouth to the anus, it's actually 3 different organs that join together during embryologic development, and it has more nerves than the brain. You're the expert. How are we going to fix this?
Well, you know, part of why I wanted to come on your podcast and why I'm so interested in working with physicians is because I think that, you know, mental health and mental illness is just shrouded with a lot of mystery, a lot of confusion. There's a lot of popular culture references to mental illness and mental health, but I don't think people really understand that we have really great treatments for mental illness.
And a lot of cultures are afraid of seeing a professional, especially my uncle. I'm Hispanic.
Yeah, absolutely.
You know, there's a fear of going, and you know, you don't need that.
Yeah, and so, you know, I think historically, mental health and physical health have been treated so separately, and we're moving towards more integrated health. But we need to be a lot more intentional about integrating them to really take out the mystery of you know, what it means to treat mental illness.
And mental health has to be put on parity with physical health, and that comes from our third-party payers.
Yeah.
You know, it's the cause of more diseases. I mean, one of the things we learned in South Florida was, unless you can identify and mitigate the social determinant, you can't get to dealing with the mental illness. And unless you can deal with the mental illness, you can't get to the physical illness.
Yeah.
So, and it underlines everything, and it's just endemic in this country.
Yeah.
You see that with the incredibly high rates of suicide. You see it in particularly communities of color. Mm-hmm. You see it in my own profession, where suicide is higher than other professions in this country. And the same thing with medical students. But we have to start off by talking about it.
Mm-hmm. Yeah. Because a lot of times people think, when you think of a psychologist, even sometimes physicians do this, when you think about a psychologist, you think about somebody who's going to be talking about ooey gooey emotions and you know, things like that. But actually psychologists are really well educated in helping people implement health promoting behaviors. And so,
and in many ways better educated than the physicians.
Yeah.
We're extremely well educated when it comes to science. Mm-hmm. But ask us about literature. Ask us about society. Ask us about things that weren't told that we had to study to become a physician. I mean, I'm old enough that when I went to college, and I went to a state school, was you had to have 2 years of university college before you could apply to an upper college. But during those 2 years, you took a bunch of liberal arts. You learned your history. You learned your philosophy.
Yeah, yeah.
We don't require that anymore.
Yeah. And I think that, you know, whenever I've worked with physicians or I've done more community service that it involves physicians, the thing I hear a lot is they express getting really frustrated that patients don't follow through with their recommendations.
With what I told them to do.
With what I told them to do, which is all determined by what is somebody's level of education, what is their social situation, what kind of supports do they have at home, what kind of means do they have to be able to pay for their medications. And mental health professionals really have the time to sit with patients and understand all of those factors that may impact whether or not they can take that one dose of medication.
Or even how to take it.
Yeah.
That's the other thing too. And we
Yeah.
found that out in some of the households we'd visit, because when we started doing the program specifically for the pediatric population with asthma, diabetes, or obesity, and what we found out was the kids with asthma, they'd give them, the mother, the inhalers. Nobody gave them the instructions on how you open the package, how much you put in. Basically, here's a prescription. And without actually having the machine in front of you and showing somebody, you're never going to learn.
Yeah. There's an immense amount of privilege that comes with knowing how to do all of that, but it also takes a lot of skill to be able to educate and explain that to patients in a way that they're going to be able to follow through on those directions.
Unfortunately, we've become so quantitative in how we appraise a student to come into medical school. The qualitative virtues that you should have, the ability to listen, the ability to translate, which is going to become more and more important in medicine, because no longer is the doctor going to be the one that does the diagnosis. You know, with all the technology we have, that's going to come out on your computer. Now we have to teach a doctor on how to translate that information to a population that has not had training in medical terminology. You know?
Yeah.
So it becomes really important. You know, very few patients show up at the ER and go, I have angina. They're going to talk to you about their chest pain. My chest hurts. That's what they're going to say. People don't perspire, they sweat. That's how people talk.
Yeah.
Not doctors. So we got to get the doctor back to stop being so elitist.
Yeah. And it's hard because, you know better than I do, but going through medical school, there's a lot of requirement to be elitist and to perform and to compete. There's a lot of
cultural pressure.
Yeah.
Which is not healthy.
Yeah.
There's a wonderful book out by Robert Pearl, who used to be the chief medical officer at the Kaiser Permanente. He's now a professor of pediatric plastic surgery at Stanford and in the School of Business. And it's called Uncaring. How the culture of medicine is killing physicians and patients.
Yeah.
And we got to be more like you all, more like the nurses. We need to go back to being the advocates for patients.
Yeah.
And if you're going to advocate for somebody, you're going to learn a way on how to communicate and how to get that information across. It becomes really important.
Yeah. It's interesting because, as I've worked with physicians, I have just a tremendous amount of empathy for physicians and how to get through medical school. It takes a particular personality to be able to push through your own discomfort. I worked with some female physicians last summer in a yoga retreat that I led for just female yoga physicians, or just female physicians. And they described how they would not drink water throughout their shift so that they wouldn't have to use the restroom in order to keep up with their colleagues, in order to make sure that they didn't have to take break from their surgeries. And so there's this self-abandonment that is almost baked into the culture in a way that,
and it's a very macho-oriented.
Yeah.
How long did you work? How many did you do? How many? And when you look at the numbers in medicine, it's embarrassing. We're racist. 5.7% of the American medical students are physicians. Our medical students are black. Yeah. We're xenophobic. Only 6% are Hispanic. We're sexist. And even though 52% of medical students are women, less than 12% are in leadership, number one. Number two, and a study done by the RAND Corporation about a year ago, a female physician of the same specialty as a male will make an average of $2 to $3 million less in her career. We're elitist.
And she'll experience more mental health issues than her male counterpart as well.
Oh, women doctors are considered better doctors and better clinicians because they're empathetic. They actually sit there and listen instead of the doctor saying, no, that's it. Tell me what it was. No, that's not what I want to listen to. And, we're elitist because medical students come from families 2 to 3 times the national average in income. And we lack virtues. And this has been known since Sir William Osler, the father of American medicine. And I have a speech of his that he gave at the University of Minnesota in 1906, where he talks about the total lack of humility in the profession. He might be because of the competition, but this is one of the virtues that have to be at the top of the list that we need to teach our physicians. Look what happens when you go to see a doctor There's no other business interaction that happens like that, where you sit in a waiting room for 2 hours. Then you get put in a room all by yourself with a gown that's like an HMO because it doesn't cover everything, a tray with instruments, gloves, KY jelly. Oh yeah, and then we have the TV screen showing you reels of disease. And we're going to put you in there by yourself until the doctor gets here with the MA. Generally, when you go to a business meeting, if you're there to see the CEO, guess who comes out and greets you? The CEO. After you tell the desk individual that you're there. So what we used to do in my practice in GI, and then we did it at the medical school, was I made the doctors go out and get their own patients. That was number one. Number two, I didn't allow them to introduce themselves as Dr. So-and-so, because right away, they caused a power differential.
Yeah.
And if you're going to use a title, please address the patient by their title. You know, it's a courtesy, a simple courtesy. But I had an ulterior motive. The more comfortable the patient felt, the better history I got. Mm-hmm. And so it worked to my advantage in the sense of I get to the history and the physical and the final diagnosis quicker.
We're going to have better patient outcomes when we have a good relationship with our patient.
You know, and it's funny when you say listen to a patient. I mean, I come from a culture of storytellers. I'm Cuban Irish. So you either drink or you tell a story, or you get in a fight. And if you're Cuban, you can smoke a cigar. But it was always about listening to stories, and then you told a story. And I had a young woman came in. My goodness, this was 40 years ago. And it's funny because type A personality, young, successful in her early 30s, attorney, but her best friend and next door neighbor in her apartment building was just diagnosed with advanced colon cancer. So she was sure she had colon cancer. She was positive. I'm here for colonoscopy. And we spent about 2 hours talking. I mean, her stress was off the wall. I remember when I asked her if you had change in bowel habits, she goes, I'm constipated. I said, how long have you been constipated? My whole life. I go, okay, that constitutes no change. That's the same. And we went through the whole thing, the whole physical exam. She had no family history. She wasn't even iron deficient. And she had no blood in her stool, so she really had no indication. I mean, I could have written an indication. Abdominal pain, you know, it got away with it. But why put somebody through a procedure that has even 1% risk of death to even do that? Mm-hmm. And so after a long discussion, I convinced her, I said, look, come back in 20 years when you're 50. And we'll do your screening colonoscopy. Well, she shows back up 20 years later. And she goes, you remember me? I said, ma'am, I'm sorry, I don't remember. And nobody keeps a medical record for 20 years. You keep it for 7. Yeah. And she goes, oh, no, I was here about 20 years ago. And you talked me out of getting the colonoscopy and told me to come back when I was 50. And I said, oh, great. Is that the advice I gave you? She goes, no. You told me to get rid of my stress. I said, oh, how did that go? She goes, I got a divorce. I said, I told you to get a divorce? She goes, no, you told me to get rid of the stress. That was what I did.
That's what she took from your recommendations, yeah.
Well, you spend time with somebody and you explain to them how emotions are related to the GI tract and how she can be more constipated when she's, you know, and all these different things. But it's once again the time to listen. Yeah. That psychiatry do. I mean, now in medical school, for goodness sakes, we do motivational interviewing. Because we bring in students that don't know how to talk.
Yeah.
That should be one of the things we look for in an admissions process.
And I'm afraid that that's going to diminish more and more with social media and with the pandemic. I think that what I'm seeing in my patient population is a lot more difficulty just having average daily communication. And there's so much that's happening in our education system that's virtual, that assignments are submitted via email, or there's virtual chats about assignments, to where there's not that education on how do we speak to each other and how do we develop a relationship.
The Zoom calls. Mm-hmm. First of all, you're staring at yourself. I haven't figured out how to not stare at myself unless I shut off the camera. When you shut off the camera, everybody thinks you left the room. I'll
teach you how to do it. I've had to do a lot of Zoom over the past couple of years, and I had to figure that out.
Okay. And, that also, and wearing the masks, as essential as that was, and I want to emphasize that, facial expressions become so important in interactions.
Yeah.
A simple smile.
Yeah. Yeah, it's one of the skills
And those that have the disability of hearing disorders and read lips, this was not a good time.
Yeah, yeah, especially stressful. Yeah, and I think that that the effects of that for especially our children and adolescents we're going to be seeing that for years to come. We're going to have to do a lot of
So what you're
retroactive education.
If I think that the mental health problem is bad now, just wait.
Unfortunately, I think that's what I'm saying, yeah.
And you know, it's sort of interesting too, because I was discussing this. We don't have enough mental health professionals. We don't have enough psychologists or even psychiatrists. And so we've got to come up with different ways of dealing with this in a population, because you can't put all the burden on an under-resourced thing. So we got to start saying, okay, what can we do out of the box that makes a difference? Now, I know that there was a study funded by Rockefeller in Vietnam a few years ago, or a couple of decades ago, about there were two cities there, both had populations of greater than 5 million. But between the two cities, they only had 2 licensed psychiatrists, and both were trained in hospitals.
Wow.
And how dealing with the cultural issue of mental illness, but how they got the mothers involved in the community just to have discussion groups. Mm-hmm. And that made a huge difference. No longer was it a hidden problem. Yeah.
We can't just rely on psychologists and psychiatrists and mental health professionals. We do have to create a community that that we have community centers and we have places for people to show up and be together and support each other.
And it can't be all biochemical.
Yeah.
It can't be all just pills.
Yeah.
You know,
it shouldn't be all pills, because
I agree.
Because what we find is that, you know, I have folks that come into my office and they say, I'm on an antidepressant, I don't understand why I'm still depressed. Well, do you have social context? Do you have a purpose in life? Are you eating? Are you sleeping?
Well, it's funny, as you were talking about the female physicians. I just read a paper by the person who, what they call the imposter syndrome, which is originally the author of that, she referred to it as the imposter phenomena. Mm-hmm. And she was a woman.
Yeah, I read this paper too.
Did you? Mm-hmm. And how she didn't think she could go to college, and she was really bright. She had a really bright older sister. So the imposter phenomena, that she didn't belong. Mm-hmm. And so one night, her and another professor, which had come up with this, they were teaching at a college, and they invited all the women in the team in the class to come to their apartment for a party. Well, as it turns out, the women that came, the students, didn't want a party. They wanted to talk. And that's when they realizes how a woman is treated in these professional environments, you know, mm-hmm. and why it becomes so important that, you know, the Y chromosome gets in the way an awful lot. And so we got to relook at these things and look at it. Even if you look at the leadership of our team, of the 6 leaders that we have there, 4 are women. Mm-hmm. And 3 are African American. I'm Hispanic, 2 are foreign born. I'm counting Canada, but that's still a foreign country. And there's 2 of us are second generation college, being that our parents were the first ones to finish high school. 2 of them are first generation. And 1 has a PhD and an MD. Yes, 5 minutes. That's what I got. I thought she was going to ask a question. All right, you guys, they're filming. This is live.
And to go on what you're saying, one of the things that can, you know, when we think about creating better systems of education, one of the things that we have to welcome is people making mistakes and welcoming people openly talking about where they're experiencing challenges. I think that, to your point, you know, imposter syndrome comes from not being able to openly share your experience without fear of being punished or without fear of being ridiculed. And, you know, having learning environments where learning is encouraged and mistakes are encouraged, because we grow through making mistakes. Now, you know, when physicians are in practice, we want to limit those mistakes as much as we can. But in our education, like getting an answer wrong or saying an incorrect answer, like we want to actually celebrate that's an okay thing. Yeah.
Which is one of the reasons why there's only 2 of us with MDs in the top 6 level. The other ones one has a doctorate of education, Cheryl. Mm-hmm. You have Maren, who has her PhD in philosophy, and she's a bioethicist. You have Lou, who has a PhD in public health and did his postdocs at the University of London in community, and who was on faculty at the University of Michigan School of Public Health, and then at FIU's Public Health before he came over and was one of the founding deans with us. And you need that diverse background. Yeah. To teach doctors how to teach. Because what is a traditional saying in medical education is see one, do one, teach one, which is really not a good idea for transplants, but that's just, throw that out there. So we have to teach differently. We have to make it an environment which is typical in medical school, it's called pimping, which you drill a medical student with questions until they get it wrong and they're embarrassed in front of their friends. That's not a very good way of retaining information.
Yeah.
So we have to start, and we have to reassess what are the qualifications to come in to be a doctor.
Yeah.
We're not looking for scientists, we're looking for clinicians.
Looking for people who want to work with humans and who are good at relating to humans.
And people that come into our profession that realize that we're a profession of service. It's not about us.
Yeah.
It's about making society better. But you do it on a daily basis with your patients, and then you do it on weekends when you do the things like you did with the rose grows in the desert. First of all, I really want to thank you for that.
Yeah, absolutely.
And number two is yoga, mindfulness, meditation. We all know that if you do those things, it helps control your blood pressure, your diabetes, and you're happier.
I had an experience once where I was working with some women who worked at a women's shelter, and I went in and taught yoga, and it was just a one-time experience, and I got an email later that said that she had gone to her physician right after our yoga session and that her blood pressure was the best it's ever been at her doctor's office. And so, it's really true that when we're implementing self-care strategies, mindfulness strategies, connection with the body strategies, and we can do that through yoga, we can do that in psychotherapy and good forms of psychotherapy. When we're really connecting to our bodies, it's going to help our health.
We started programs in South Florida. Now, these are the most vulnerable. We had 99% of our families were uninsured. But we started mindfulness with them. We called it mindfulness not for the housewives of Beverly Hills. They didn't have time to go for an 8-week course.
Yeah.
But we knew that if they did it correctly, it would help control their blood pressure and their sugars and make them better people.
Yeah.
So I want to really thank you for being here, number one. Number two, obviously you've trained us that physicians are very poorly trained in mental health.
Yeah.
And sometimes we can cause some of the disorders.
Yeah, absolutely.
And you got to think about things. When you tell a patient and you use the word cancer, you've just said the C word. If you don't have a sure diagnosis, you have left that poor person. Or when we send somebody for an MRI and we say, we'll call you with the results, and it's a week.
Yeah.
You don't think they're nervous?
Yeah.
Especially when they're getting the MRI, the technician that's doing this is in another room. No, I can't go in there, but you're fine.
Yeah.
And so we don't even think of these little nuances.
Yeah.
You need to teach us. And
Happy
you need to emphasize this with our students, and I'm inviting you down to speak to the students.
Would happily do it.
Fantastic. So, let me make sure I pronounce it correctly this time. Koch.
Yeah.
Yes, got it. Whitney Koch Owens, a PhD in psychology, a brilliant clinician, and more importantly, an individual that understands the importance of community and helping and giving back. All that from a leadership position. Thank you for taking the time to be with us. Let's make the world better. Be kind to people. You don't know what they went through last night or the week before or the year before. And with that, because of people like Whitney, I know the world will be better. Thank you.
Thank you so much.
Thank you.
If you enjoyed today's podcast, please subscribe, like, and comment on your favorite podcast platform. If you'd like to support the groundbreaking work that Dr. Greer is doing at the Roseman University College of Medicine, please donate at the link below. Thanks for tuning in to No Laughing Matter with Cuba Pete, as together we work to unite the heart and science of healthcare to serve all in our communities. See you next time.